Welcome to our webinar, Combination Therapies for Refractory and Relapsed AML. Thank you for joining us. My name is Lee Clark, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of patients, families, and caregivers for supporting the program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the program, you can call in to hear the audio portion using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you have finished typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help us manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert cannot answer any specific questions related to your personal health care. Today's expert is Dr. Ivana Gojo, who is a hematologist oncologist in Baltimore. Her clinical focus is on diagnosis and management of patients with acute leukemias and other myeloid malignancies, with emphasis on the development of novel therapeutic approaches for these diseases. She is nationally and internationally recognized expert in clinical translation of novel therapeutics for leukemias and is a primary investigator on multiple multi-center investigator-initiated studies. She joined the Johns Hopkins faculty in 2012 as the co-director of the Leukemia Drug Development Program. With that said, it is my pleasure to welcome our expert today. Thank you for joining us.
Thank you. I would like just to make sure that everyone hears me. Thank you on nice introduction. It is my pleasure today to be able to share some of my background knowledge and research in the management of patients with acute leukemia. And I'll try to put some questions that I find to be relevant for patients and that maybe do not come routinely in the discussions. So with that in mind, just please bear with me because, okay, so these are my disclosures. So let's start first, what is acute myeloid leukemia? I know I am speaking to aplastic anemia and MDS Foundation, but I want to kind of first to touch up on what is AML really. So AML is cancer that involves bone marrow and blood. And I usually, when I try to explain my patients what disease they have, I start explaining that bone marrow is a factory that produces all blood cells, because it is easy to imagine why important heart is, but it's very hard sometimes. There is no this global picture. Why do we need bone marrow? So, but bone marrow is very busy organ and it produces all blood cells that we need, including white blood cells that we need to fight infections. So red blood cells carry oxygen and make us feel better, and platelets that help us to stop bleeding if we cut ourselves, so help our blood to clot. So what happens in acute myeloid leukemia is that patients with AML have a bone marrow replaced by AML blasts. These are very primitive cells. And of note, I will just say that white blood cells do not look like this because I just now realized they look similar like blasts, but no, this look a little bit different, and that will be healthy white blood cells. But generally in leukemia, they are primitive blast cells. They occupy the space. And what happens, they really suppress normal bone marrow. And as a consequence, patients have usually low healthy white blood cells. It doesn't necessarily mean low white blood cells, because white blood cells sometimes can be very high, but they are blasts. They are not healthy. So that leads to infection, low red blood cells, which causes anemia and lots of associated symptoms like fatigue, shortness of breath, or it might cause bleeding or bruising when platelets are low. And usually supportive care then includes management of infection and treatment of anemia and bleeding. But I am here to discuss today relapsed refractory AML. How large is this problem? So I think it's important to realize that as our population ages, median age of patients with acute leukemia is getting higher and higher. So 1/3 of the patients are above age 75. And looking in the new cases, it's estimated that these are not good numbers, particularly in terms of outcome, or looking in 5-year survival only of 27%. So let me introduce you to these curves. What does these curves mean? So this is the studies that examine the outcome of patients with acute myeloid leukemia who are younger than 60 and older than 60 that have been treated in the period from 1970 to 2009 on different treatment regimens, but by the same group. And what does it show? That actually with time, which means in more recent period from 2000 to 2010, the outcomes are better than they were previously, but still, majority of patients with AML are not cured. And that means most of them will be either refractory or their disease will relapse. And this arrow is really concerning, and I would say scary to look at people who are age 60 and above, and yet these are the most of the patients who have acute myeloid leukemia. So the scope of the problem is pretty large, I would say. Now, my intention here is not to confuse anyone, but I use this slide because I am trying to point out few things. First, lots of times patients ask me, oh, you know, my friend was diagnosed with acute myeloid leukemia and they got this and they are doing great. Why don't I get this? And so on. So AML is very complex disease. And actually, I think I would call it AMLs because I truthfully don't know that I have a single patient that is has same disease as other. So this is very heterogeneous disease. Now, when I started treating patients with AML, which probably is 20 or so years ago, we really didn't have many sensitive tests. We were kind of able to look in basic chromosome spread and say, oh, you have these changes, so this is favorable, intermediate or poor risk AML based on long-term outcomes. But these days we do more deeper analysis and we realize that it's not just one mutation, but that our patients may carry many mutations and some of them will interact, some of them are exclusive. We also know that it's not just gene changes, but then that there are epigenetic changes that can happen in AML and influence the outcomes. And lastly, clone. What does it clone mean? Kind of idea is if you have one mutation or 3 mutations, that is really in all leukemia cells, but that's not really true. And usually instead of one clone, you may have several clones. And actually then at the time of relapse, these clones might be totally different or maybe overlapping from initial one. And why I'm saying this? Well, first I'm giving talk here at aplastic anemia MDS, and these are the processes that occur over time. So when I need to think about clonalities, I would say that this could be particularly problem here. Another thing is because I always want to teach my patients to ask your doctor if your disease has come back. Did you repeat my molecular studies? Did you do my chromosome studies? Because it doesn't mean when your leukemia comes back that it's absolutely the same. And I'll get a little bit more to it. So again, frequently question is, what is the stage of my AML? And it's hard to explain. There is no stage in AML. You either have it or you don't have it. At the end of the day, whether you have 5, 20, or 25, or 100% blast does not necessarily make any prognostic significance. There are many classifications of AML, including World Health Organization, but I think that what we really most commonly as a physician implement in practice is kind of trying to separate these chromosome findings and some mutations, and on base of that decide, this is favorable risk. What does that really mean? It doesn't mean that people who have favorable risk leukemia are all cured from leukemia, but we kind of think that maybe these patients have a chance to be at least 50% or a little bit more cured by chemotherapy alone. So maybe we won't rush to transplant right away. For intermediate and advanced group, well, we might consider transplant earlier. So it's really having more prognostic, how do we go from here? On the other hand, knowing mutations certainly influence also our target therapies, but I'm going to get to that. Now, this is more relevant for diagnosis, but maybe if you hear your doctor saying you have favorable, intermediate, adverse, at least that you have a concept. Ultimately, when you have relapsed refractory leukemia, this plays a little bit less role. Now, I always, obviously my job is translation and trying to develop novel therapies for patients with AML, but what I want to emphasize here, this is impressive. Up to 2000, we really had only cytarabine or drugs called anthracycline and few more to treat patients with leukemia, and actually not much happened until the last 4 or 5 years. I would say that the approval of drugs like azacitidine or decitabine, which were approved with MDS and hypomethylating agent, probably spurred the research. And so many novel drugs have been approved over the recent years. Now, I placed in red those drugs that are approved for patients who have relapsed or refractory disease and maybe some unique mutations. So nothing of this would be possible without clinical trial participation. So how do we diagnose relapsed AML? So I think it's a standard. It's always patients' symptoms. Usually people who have, and this is relapse disease, who have AML, they kind of know how to recognize symptoms when they don't feel well, when they have fevers, when they have bleeding, bruising, unhealing infection, and so on, although that could be a variety of symptoms. And then physical examination obviously can point to some of these findings, but generally you do need blood count and blood smear because we can have leukemia cells in peripheral blood, and also chemistries frequently because they can be altered with leukemia. But then we do bone marrow tests, and it's a bone marrow aspiration and biopsy. Sometimes if we have lots of blast in peripheral blood, sometimes we don't need to do it all the time. So what we do flow cytometry, which is kind of, we collect bone marrow cells, we kind of stain these cells with different markers, and we know color for each marker. So when we put through the machine, we can figure out which markers individual cells express, and then we know which type of leukemia patient has. Then we already discussed cytogenetic analysis. We want to see what is the chromosome spread. Are there additional abnormalities? And then particularly molecular testing has become exceedingly important in AML. Well, now some mutations we can monitor by PCR, but usually these are kind of special type of leukemia, like acute promyelocytic leukemia, core binding factors leukemia. But for all leukemias, we always look in next generation sequencing, which can give us lots of information on mutations. And that brings me to something what I mentioned previously. Patient will sometimes say, oh, I had all this mutation tested when I was diagnosed. It doesn't matter. When your disease come back, you should have it done again, because I show you the picture that tells you that you don't need necessarily have to same. You might have same, you might have similar, or you might even have different leukemias, and that's very relevant. So then we are coming, okay, we are dealing with relapsed refractory AML. So what do I need to know to make therapeutic decision? How do I talk with my patient and establish goals of care? I think it is very important, because we saw that majority of patients are of older age, and we also know that for those patients, aggressive therapies or transplants might not be options. Or it could be that patient is relapsing very quickly post-transplant. So I think we really need to put for patient in perspective, what do you expect from this treatment once your leukemia is back? So looking in patient age, performance status, and fitness, question can be, what does it really mean? But in reality, you know, in addition to that, does patient has active infection? Is patient post-transplant and it's on immune suppression? That this patient has graft versus host disease? What is the organ function? We also look in disease characteristic. What patient has leukemia, has mutations and abnormalities? How long did the patient respond with first to chemotherapy or was refractory? What are the prior treatments? Is there prior transplant? What type of donor for transplant? And on and on. And then very important part of that is patient preference, as well as a social support is extremely relevant for our patients. And so I'm just going to go a little bit back to answer this question, why we ask, is AML relapsing post-transplant? Well, because we know it's not only question is, but how late after transplant leukemia relapse. Because what these curves show us, it shows us probability of survival years after relapse. So if your leukemia relapse very early on after transplant, within first year or so, or 6 months it's here, the chance of long-term survival is low. But if your leukemia relapse 2 to 3 years post-transplant, then we might have very reasonable chance to put this leukemia in durable remission. And again, when we did adjustment for these factors and we look at the age, we can see that unfortunately older patients these outcomes are poorer. So I think these are why these questions are important. We also, from doctor's perspective, we want to know if patient has active GV, graft versus host disease, because if patient has that and still relapse, that's not good. We also know that maybe conditioning intensity might influence outcomes later on. In other words, how much of chemotherapy intense you got in the past, are you going to be able to tolerate future chemotherapy? And then we know that there are some leukemias that just don't respond to chemotherapy. So the fact that we can do it and give it doesn't mean it's right, and maybe we should consider alternatives. And again, also when patients, frequently I really hear that commonly, my husband or my wife was doing perfectly fine until they were diagnosed with leukemia. And that might be true, because it is true that leukemia makes you anemic, makes you tired. So it might really alter and give you a little bit false impression on overall performance, status, or fitness. But there are some, so it's generally when saying when someone is fit or not fit, it has been lots of gestalt from the physician. Oh, I don't think this patient is fit, doesn't look good. But there are some objective measures actually that can tell you that just capturing how quickly someone can walk can really substantially discriminate survival. And in other words, this is indirect, showing us is patient likely or not likely to tolerate any chemotherapy. So this is just, I tried to pose few questions for you just to think about these things. And unfortunately, you have to have been dealing with this disease or someone of your close one. Now, I will ask this question, can we make sense of this? So this is National Comprehensive Cancer Center Network, and these are recommendations that many physicians use, and I happen to sit on this panel. And you may ask your question, so here, relapsed refractory leukemia, so we do recommend comprehensive profiling to see what are the mutations, because particularly if there are some genes that we can target. But then you can see what are your options for treatment, clinical trial, and that's true. We truly prefer clinical trials, but then or targeted therapy followed by match or alternative donor transplant, or chemotherapy, or repeat initial successful chemotherapy, or best supportive care. What our patients want to know, and that's a part that I tried to present earlier, which or does fit me best. And continuing with that, it's even more extensive list. So again, clinical trial, extremely important. I am really supporter of clinical trials because that's the only way how we can make progress. And actually, many of the targeted therapies that maybe someone who has relapsed refractory leukemia may not benefit from are available in the context of the clinical trial, and it might take time until they get approved. So they're always positive. So it's interesting, you will see that there are kind of two columns. One said targeted therapy, and I'll discuss this a little bit more, but there are targeted therapies these days where we can specifically target mutations. And that's why I said previously, let's do genomic testing. And then you hear now, because number of different chemotherapy names, I'm not going to read them aloud, but you can see there is a lot of overlap with cytarabine because it's usually used in all regimens. But then you have different anthracyclines, different additional drug, and then of course hypomethylating agents, low dose cytarabine, and this venetoclax is newly approved drug actually several years ago. So, in combination. So you can see this list. So the question becomes, maybe this is a bit easier, patient has mutation, but where do I select this and why this list? I'll explain you where is this list coming from. This is actually a group of investigators to try to look at hundreds and hundreds of clinical trials that have been reported in acute leukemia, myeloid leukemia, and relapsed refractory setting using different regimens. Again, same, they use cytarabine, but they use different combination of this additional drug, fludarabine, cladribine, and so on. And this is complete remission rate. So pretty much what you can see that adding additional chemotherapy may slightly increase response rate, maybe up to 50% or so at maximum. It will also increase toxicity, just to make it clear. So ultimately, when you come to this median overall survival, maybe there are occasional studies, and this is usually a single institution study or something, show that there is some survival benefit, but in general, usually median survival is between 6 to 8.7 months. So that's not really different. So ultimately, when I'm asked what is the chemotherapy regimen better, I would say that it depends on the patient. Sometimes regimens like CLABM, FLAG-M, or FLAG-IDA may improve responses, but might have more toxicity, so may not be well designed for every patient, and sometimes just using high-dose cytarabine would be enough. Important is also where are you treated, because maybe an institution where you're getting treatment, physicians have experience with one type of regimen, not another, and it's not uncommon. Even here at Hopkins, we prefer certain regimen of another, so I guess our experience will be more with one than another. So that's why I don't want to spend lots of time discussing each individual regimen, because I mean, I can spend next 30 minutes discussing that, but I don't think that's really going to be very helpful. So what I want to, and that's what my whole career is, it's always asking the question, can we do something better for our patient? Is there something that we can improve efficacy of chemotherapy regimen? So I didn't spend much time earlier addressing this drug called venetoclax, but this is now approved drug for older patients and given in combination with low-dose chemotherapy, azacitidine. It's a standard of care for newly diagnosed patients. And how venetoclax works? So venetoclax works really by inhibiting this protein BCL2, which is protein that blocks cells from dying, okay? So it is overexpressed in AML cell and in leukemia stem cell. And when this protein is high, it's kind of increasing the threshold to make the cell die. So when you add venetoclax, you actually hope to relieve this, to reduce this threshold. So if you give additional chemotherapy, that cells might be easier to die, make them easier to die. So, of course, once the drug was approved, and this is how typically happens in acute leukemia, once the drug is approved in some setting, then we try to spread it to all the settings. So, among attempts to improve outcome is this trying to add venetoclax BCL2 inhibitor to flag either regimen, which is intensive chemotherapy regimen for relapse refractory, although it's being used in newly diagnosed patients. And actually, I put several slides, and obviously these are busy and confusing slides, but I want to just get that you get a sense how we do study. So we start with phase 1. So the doctors, they started this, and MD Anderson, they said, okay, let's add venetoclax to our standard regimen of fludarabine, cytarabine, and let's see how it's tolerable. And that's a phase 1. And what they found, we have patients who develop really lots of infections. So maybe when we are adding this drug, we will need to adjust dose of chemotherapy we are using. And we might not be able to give this drug for 21 days as it's approved for low intensity chemotherapy, but maybe more 14 days. And that's once you define that you can safely do this, then you go to phase 2. And then for what happens uniquely to this study, they were testing in newly diagnosed, but also in relapsed refractory patients, which is the topic what I'm discussing today. So one thing, adding additional drug, again, re-emphasizing what I mentioned earlier, well, if we know that they can be easily tolerated, you just add new drug, we would be adding drugs to every new regimen that we know that is good. But the problem is there are toxicities, as I already mentioned. So if you use higher doses of drug, or maybe you add just new drug, you might have periods of long myelosuppression. And so maybe you can put more leukemia in remission, but maybe you might have patients dying because it takes longer for their counts to recover. And that's why we are getting back to that, why we need clinical study. But to point with you, when this study was taken from phase 1 to phase 2, they found that up to 70% of patients responded to this combination with venetoclax. Actually, CR responses were 61%, and MRD negative responses up to 80%. MRD negative means that you couldn't really even detect any residual disease. So this is very encouraging, because if you recall slide I showed earlier, for most chemotherapy trials, at most responses were 50%. So the next question is, okay, we have a better responses, but do we have better survival? And I'm not going to go in detail here claiming anything because first, these are small number, but at least at this point, for patients who are relapsed refractory, 1 year overall survival, and this is a phase 2. So this is phase 1 relapsed refractory. I would like you to concentrate on this because this is when the dose is defined, is a 68%, which is encouraging. And there is a longer time for them to stay in remission. Obviously, it's not as good as when you are newly diagnosed, and that's why I always support when people are diagnosed with leukemia, use all of your guns early on, because that's when you have highest chance to cure this disease. Okay, so this is what, so now let me get to another part. So FLT3 and lots of patients, well, patients who have leukemias that are FLT3 mutated know that. But just to explain what is FLT3, so FLT3 is important like a growth factor for leukemia cells. It's a receptor on the surface of all, myeloid cells, or particularly early cells. But the issue with FLT3 that it becomes mutated in some parts, and as a result, this FLT3, like a growth factor, is just pumping up, pushing leukemia cells to divide and grow. And so this mutation happens in up to 1/3, little bit less of patients with AML, I would say 1/4. What is interesting is that, and it's associated with really poor outcome, and particularly if it's lots of mutation. Now, for years, people will try to develop inhibitors to FLT3, and again, there are several, and there are a number of inhibitors in clinical trials, so there are actually type 1 and type 2 inhibitors. And when you treat FLT3 mutated leukemia with one of these inhibitors and disease progress, sometimes maybe other inhibitors may still work. And I'll explain that as I go through this. So again, we are discussing combination chemotherapies, but look here. This is Admiral study. This is a randomized study where in patients with FLT3 relapsed refractory mutated AML, you give single oral drug called gilteritinib versus salvage chemotherapy, like that list that I show you. And single drug actually cause more remission, I mean here 34 versus 15%, and actually significantly improve survival compared to chemotherapy. So I think these days we really need to be careful because actually sometimes single drug for some of these specifically mutated leukemias might be more effective than a whole bunch of them. And that's again, going back to saying, always ask your doctor, do I still have mutation and what mutation I have? And it's important to know which FLT3 inhibitor did you get. And actually, this is one more showing that in patients who achieve remission and went to transplant and they continue to take gilteritinib, they live much longer and some of them were cured compared to those who stopped. So this is really our critical information, because if disease relapse and you put it in remission and you stop the drug, go to transplant, well, you have a great chance of relapsing again unless we do something more. Now, what is important that, and this is just for remember for FLT3 mutations, as I mentioned, some of these patients with FLT3 mutated leukemia were treated with FLT3 inhibitors and they progressed. And why I'm showing you this, I'm sorry, I'm losing my pointer sometimes, that actually at relapse or progression, some of these patients may lose totally FLT3 mutation, or they might acquire different mutations. So that's why it's important. And so if you give just FLT3 inhibitor without checking this, well, then you might not achieve any benefit. And then we know that there are some acquired mutations in some other genes. And we also learned, and some of these maybe like BCR-ABL, or we know that there are some IDH mutation could be differently targetable. So it is, that's why I'm re-emphasizing again that AML is lively, and that could be fortunately or unfortunately, but just as you think you hit something, they find a way. They're very smart. They are small cells, but extremely smart. They know how to avoid chemotherapy or what we use. Okay, I will now get to another set of drugs that I mentioned earlier that have been approved for treatment of relapsed refractory leukemia that have this IDH1 or 2 mutation. And it happens in 7 to 14, 8 to 19% of patients that have this mutation. So how this mutation works, they pretty much create accumulation of this oncometabolite hydroxyglutarate. And then when there is too much of this, then there is a block in differentiation, and because it induces changes in transcription of genes. So with that in mind, so first drug called enacidanib, which is approved IDH2 inhibitor, again was given as a single drug in patients with IDH2 mutation AML, but an overall response was close to 40%, and more than half of patients, actually close to 3/4 of patients, really had complete remission. I know that median duration was not great, it was 5.6, but it opens opportunity that you don't need to induce major toxicity, and that for some of these patients, you might be able to put them in remission and then take them potentially to transplant. Also, this drug is now explored in upfront settings similar to venetoclax, as well in combination with low-intensity chemotherapy and in relapsed refractory and newly diagnosed setting. So, similar thing was observed with ivosidenib, which inhibits IDH2. Again, new therapy option, wonderful. Response 40%. And 30-some% is complete remission, duration 6.5 months. So I think this is really remarkable to see, again, that with a single drug, you might achieve efficacy as good as with complex chemotherapy. And again, this drug is also being combined with different chemotherapies, less and more intense in upfront and in relapse setting. Okay, now this is important slide, okay? Well, sometimes knowing mutation may help us to select best treatment because we have now targeted drug, as I just now mentioned, FLT3 inhibitors, IDH1 or 2 inhibitors. But sometimes knowing mutation can also allow us to have more informed discussion with the patient. And I know that I'm talking possibly to a plastic anemia MDS population, and TP53 is our big enemy. Actually, when we have it, when it's not mutated, it's great, but when it's mutated and it's associated with complex karyotype, and that more commonly happens in older patients and in those who were previously treated either for solid tumors or maybe for MDS and so on. The problem is, if you give these patients intensive chemotherapy, you might actually do worse than better because they may have lots of toxicity and yet for no real benefit. I mean, not all mutations are same, so I don't want to equalize them, but in general, they are bad, particularly if they are associated with complex karyotype and high level. And as you can see, this is another way to look. If patients really have high level of this mutation on genomic screening, these are bad outcomes, whereas less may not so much influence outcome. But I'm saying this, so instead of finishing, and I frequently see this, because as a physician and we want to treat our patients, as a patient you want to get treatment and get better, but sometimes giving you chemotherapy may not necessarily do much good. And so it's important to know what to expect, because for someone who might be 80-year-old may say, well, why don't I get supportive care? Why should I get through something that probably won't change much for me? But on the other hand, we know that there are clinical studies, and there are currently at least 3 agents that appear to be highly promising in this patient population. Flotetuzumab, which is bispecific antibody, which actually successfully put in remission some of patients with TP53 mutations who were primarily refractory to chemotherapy. Then there is APR-246, now has new name, which is TP53 reactivator. And then this wonderful drug called magrolimab, which is actually a checkpoint inhibitor that kind of leukemia cells kind of express on its surface do not eat me signal, but when you block that signal with magrolimab, then macrophages come and eat leukemia cells. So we are quite excited about it. So I hope that we'll be able to offer something to these patients. And then lastly, just to show where we are trending, so besides, we already discussed IDH1, 2, FLT3, TP53, but there are many other drugs that are being developed to target different mutations in AML. For example, there is this drug called KO539, which is selective inhibitor of something called menin KMT2A mixed lineage leukemia complex. Now, MLL rearranged leukemias and NPM1 mutated leukemia seems to be dependent on this complex because it actually promotes, X on the promoters, regulars, MACE, and HOXA promoters, and ultimately promotes leukemia. And when this, and ultimately this inhibitor allows actually leukemia cells to differentiate, to mature, okay? And so with that in mind, again, this is just description what I mentioned to you previously. This is the phase 1 study that was presented just actually fresh from the press few months ago in our yearly Society of Hematology meeting. So how do we test these new drugs? We start low in the phase 1, we slowly escalate, we monitor for toxicity until we define the best dose. But what is interesting, just to mention, that this drug actually already put some patient in complete remission at very low dose levels. So we are excited about it, and this study continues. And I think I'm getting to the point of where I want to summarize all of this, what I was talking about for you. And I know it's a busy slide, but bear with me. So what do I do for my relapsed refractory AML patient? So based on these circles that I showed you previously, first we have friend discussion. We assess, are you fit for intensive chemotherapy or not? Usually who are fit patients are those who are younger, who have good performance status, organ function. We might be prone more to give intensive chemotherapy for those patients who had very durable first remission more than 1 year, and we might consider repeating even the same therapy. Though we also may consider it in patients who did not relapse within first 6 months, 1 year post-transplant, and patients who really don't have terrible karyotype of TP53 mutation where we know that this may not work. I still, even in these patients who are young and fit for intensive chemotherapy, I always repeat genomic screening, genetics and everything, and look for the mutation that at this point I can target to give single inhibitor or in combination with chemotherapy. I absolutely screen every patient for clinical trial because many new good things are actually in clinical trials and frequently not, it takes time to get it approved. But for, let's say, if I don't have anything, then I may consider for this population intensive chemotherapy. I know that even if I put my patient in complete remission, which means when you clear leukemia from the bone marrow, whichever mean I use, that achieving complete remission does not guarantee cure. And if someone is young and fit, we really try to be aggressive, and we would consider second allogeneic transplant in patient had transplant before, or we might consider donor lymphocyte infusion, or we might consider first transplant for those patients who never received the transplant. If patient is unfit or not good candidate for intensive chemotherapy, that's not just all the patients, because we transplant patients with older age these days, but usually patients who have poorer performance status, above age 75, not good organ function, or patients who really have terrible disease where remission is so short, or they relapse within 6 months post-transplant, and they have this complex karyotype, well, then I don't think it's right, because to give them intensive chemotherapy, because maybe we will cause more damage keeping them in hospital treating infection instead of having them having some quality of life. For this patient, I do consider again targeted therapy. I told you single agent can induce remission and have good quality of life impact on patients, because actually responding to leukemia gives you better quality of life than those that you don't respond because you need transfusions, yada, yada, you're prone to infections. Clinical trial always. And then you consider if this is not really something that your patient fit in, then maybe low intensity chemotherapy. But if it's really bad disease and patient doesn't feel good, and it might be very hard for a variety of the reasons, social, financial, any, sometimes supportive care might be actually giving some good quality of life for a patient and family. And actually with better antibiotics these days, there are a number of patients and better supportive care. We can help lots of patients without treating them aggressively with chemotherapy if that's not in their interest. Also, I want to emphasize that putting patient in this not a good candidate or unfit does not absolutely exclude patient's ability to proceed to allogeneic transplant, because actually among patients who achieve CR, some patients will really improve performance status, will look good, organ function will be good, and we will take these patients to transplant. So it's not immediate lack of, oh, we won't transplant you. I always tell patients, you know, you might be in a little bit riskier group, but let's see how things go with treatment, you know, and if you feel better, well, maybe we might get there. So I hope I tried to answer some of your questions. I appreciate your joining, and I appreciate Aplastic Anemia MDS group for organizing that, and then also all of you who hopefully will have chance to listen this now or in the future. Thank you.
Thank you so much for the wonderful presentation. We have a few questions. Our first question says, can you please discuss CAR-T CD33, CD123 causing problems with hematopoiesis, irreversible damage?
So I can discuss that. I would say that this is still not fully answered question. It's a still research question. There were lots of concern that administering CAR T cells which target CD33 and CD123, which are also expressed on the surface of normal stem cell, may result in ultimately damaging normal hematopoiesis. But I don't think that we have absolute data suggesting that. When it came to the clinic, I will just give you example, and it's a little bit different than CAR T cells, but these days similar concerns were, for example, when we try to use bispecific antibodies like BiTE antibodies to the target CD33 and CD123, and there was a concern that just targeting these two antigens will kill normal cells, and since we are going to activate T cells, patients can get in trouble. But let me answer that at least so far, patients don't have problem. I mean, problem is to get patients to respond, but among those patients who respond, they recover counts. So obviously there are different CAR T cell products. Persistence of T cells might be different. Initial studies are looking in doing that in conjunction with allogeneic transplant. So I think or putting something they call suicide genes. So you kind of kill T cells that you infuse when you think that they are causing toxicity. To some, it's a question of research, but I would say that we still, in acute myeloid leukemia, different from acute lymphoid leukemia, we still have more problems having them being effective than really causing extreme toxicities. And I would stop there.
Thank you. This next question comes from a patient who had a transplant 3.5 years ago for AML, and it appears that the transplant is failing. The question is, what does research say regarding looking to have a second transplant? Is it better to consider drug therapy? How do doctors decide which is the best course? And what kind of questions should this patient be asking to determine what is the best course to go from here?
Thank you for this question. Yes, it's very tough to hear when you just think that you're cured from this disease comes back. So I think there are several important questions. I think some of the questions I try to stress while doing presentation is this question: what is my disease now? Do I have same disease? What are these mutations, cytogenetics, whatever, is there something new, or is it the same? But do we have something new for this mutation that evolved over the last 3 years? So this is the first question. The second thing, I always want to make it clear, for any allogeneic transplant or any donor lymphocyte infusion to work, including second transplant specifically, you first need to be in remission. Giving transplant with active disease generally does not work. So I do believe, if your question, again, I cannot go in details because I don't know details of the case, but when patient relapse, the key is actually really first put patient in remission and then consider second transplant as a consolidation. Again, another question to ask is, should I have the same or different donor? Because there are different type of transplants, and it's beyond for me now to discuss that, but there are some data to suggest that alternative donors, different donors might be better, but that's something you do need to ask your doctor. I would go from there. So I wouldn't say if your aim of your treatment is cure and you're in good shape, aim should try to be cured again if that's realistic based on the nature of your leukemia. But it is important to recheck this leukemia from all the aspects and then design the plan with the goal to put you in remission and take to transplant. And that's what I can recommend.
Thank you. Our next question comes from a patient who seems to be doing very well with their treatment for AML, and they're still on the fence about whether to receive the COVID vaccine. The concern is potential relapse of disease or a decline in counts. Do we have any data to help patients or any advice for patients?
Oh, sure. So no, we don't have any data to suggest that COVID vaccine has any association with the AML relapse risk. I would agree it's a short period of time, but generally, let's put back something in perspective. When our patients who have AML go for transplant and they recover from transplant, they pretty much get back all their baby vaccines. For 2 years, they are getting vaccines, and we never had issue. Actually, our issue was always, is my patient going to respond well to vaccines so they don't get infection? So I don't think that we have any data to suggest that getting COVID vaccine in AML patient who is in remission has any detrimental effect at this point, at least based on the data that we have. And we generally follow CDC recommendation and have recommended all our patients to get vaccinated, including our patients who are now getting chemotherapy. We are trying to kind of to adjust it to get it during period when maybe their immune system is more likely to respond. So our concern is rather only if patient is on active therapy or patient got chemotherapy or older patient, are these patients going to respond to vaccination? So my advice is always, yes, please get vaccine. You don't want to get sick with COVID-19.
Thank you. This next question comes from a spouse whose wife is a high-risk MDS patient, and there is a concern about the transformation to AML. The question is, the advice would be, should they look to move towards transplant to head off a transition to AML, or should they engage in drug therapy to see if the disease can get under control? How do patients decide in that situation how to proceed?
Absolutely, and I'll give you, so I always, let's put it in this perspective. If someone has a high risk MDS, what does that mean? That person either has bad chromosomes or have increased number of blasts in the bone marrow. And you know, there is a very fine line that divides high-risk MDS from AML. Is actually, do you have 20 or less than 20% blast? And to be frank, I don't think it's much science there. It's kind of how we decided. There's some data, but nobody can convince me that having 17% blast or 24% makes big difference for patients. So if someone has high-risk AML, or MDS, I apologize, we know that these are the patients that with time will just accumulate more blasts and transform to acute leukemia. So we would like to intervene now, maybe when they have 10 or 7 or 8% blasts, rather than wait when they have 40% blast, okay? That's one thing. Second thing, transplant. Okay, if we are going to intervene, if you have 14% blast, let's say, I'm just giving this number, we want we want you to have less than 5% blast to take you to transplant, because the same rule applies that if you have more blast and your disease in remission, the chance the transplant is going to work is less. So you may ask, so if I start chemotherapy, maybe I'll be fine because we can give you azacitidine, and you know, there is a nice number of patients who respond to that. That's true. The only problem is, and this is my usually rule of thumb, if I decided together with you that you have a high risk MDS, that you deserve to start chemotherapy with azacitidine, if you are in age, performance, and health-wise group that is eligible for transplant, then our goal would be to put your disease in remission and take you to transplant to cure your disease. Because some patients will come and say, oh, I'm doing fine, I have remission with azacitidine, and that's wonderful. But usually most remission to azacitidine lasts at most year and a half. So it's a kind of, and so what happened in a year and a half? When you have azacitidine that you use, your disease is progressing, very few things work well. So if person has high risk MDS, then yes, earlier the better, to try to treat mostly azacitidine or clinical study, and then to plan immediately as you start this therapy, that you immediately have a plan with your doctor about transplant. Because there is, you know, majority of people receiving azacitidine will relapse.
Thank you so much, Dr. Gojo, for spending your time and your expertise with all of us today. If you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If we were not able to answer your question today, please send it to us anytime in 3 ways. Send an email to our help account, which is help@aamds.org. Call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are always here to support you and your family as we have done for the past 37 years. This concludes our program. Thank you again.
Thank you. Thank you. My pleasure.